This part of our presentation is about new vision on damage in SLE with Dr. Ian Bruce. Damage is an important outcome in SLE patients as it reflects chronic complications of the condition, such as cataracts, strokes, and skin scarring. The original damage index was developed 30 years ago. This current project seeks to develop a new damage index for lupus that will reflect modern medical practice and also be a more precise measure so that we can better identify and study how new treatments can help improve long-term outcomes for people living with lupus. Professor Bruce is Pro-Vice Chancellor, Faculty of Medicine, Health, and Life Sciences at Queen's University Belfast and National Institute for Health Research, Senior Investigator Emeritus, and Professor of Rheumatology at the University of Manchester. Studying and practicing medicine in Ireland, Dr. Bruce also spent 1996 to 1998 as a Geoff Carr Fellow at the University of Toronto. His lupus research has influenced NHS England policies and NICE guidelines that have widened across to novel therapies for patients with SLE. His work has also highlighted the excess cardiovascular risk associated with SLE that has influenced British and European SLE management guidelines. He is currently chief investigator on a project developing a new damage index for SLE in collaboration with the Systemic Lupus International Collaborating Clinics, the Lupus Foundation of America, and the American College of Rheumatology. Welcome, Dr. Bruce.
Thank you very much, Lisa. That's very kind of you. And I'll just, shall I share my slides or do you have the slide? I can share my slides and it's probably easier.
Yeah, we'll have you
Yeah,
share
if you
your
can
slides.
share, that would be best. I have them on backup, but
Okay. Right. So hopefully you can see that. Can everybody see that slide?
Yes.
yes, that's good.
Lovely. Okay. So I'm just going to talk to you briefly today about a new vision for damage in lupus. And it's a real pleasure to be invited to speak to Lupus Ontario for the obvious reasons that Lisa outlined, which was that I was a Geoff Carr Fellow in 1996 working at the Toronto Lupus Clinic. So these are my disclosures. I'm going to give you a little bit of background, first of all, a little bit of personal background, and then a little bit of background to why we're interested in damage as an outcome in patients with lupus, what drives damage in lupus and why it's important that we study it, and then what we're doing to update the damage index for the 21st century. So if you took a career summary, I qualified in medicine in Belfast, Northern Ireland in 1988 and specialized in rheumatology with a strong interest in both vasculitis and lupus. And so in 1995, I wrote to Professor Gladman in Toronto and said to her, because of the work that I was doing in Belfast, I'd be very interested to come and work in Toronto for a while to understand what they were doing on cardiovascular risk in lupus. So they very kindly, in those days it was the Ontario Lupus Association, but it was still the Geoff Carr Fellowship, and I was successful in getting that. So I started in Toronto in August 1996, so pretty much exactly 30 years ago. While I was there, I also did psoriatic work with Professor Gladman. Then I moved to Manchester and actually still have a part appointment 20% in Manchester. I developed a lupus clinic and a systemic multi-system disease clinic, which became a regional service for the northwest of England. And I also led a lot of the National Institute for Health Research infrastructure in Manchester, including the research facility and the Biomedical Research Centre. So this is just me many, many years ago, younger and bearded in a snowy, typical downtown Toronto afternoon in sort of the winter time. And my daughter, who's the smaller one, really wrapped up with just her eyes showing. Maeve was actually born in Mount Sinai Hospital in February 1997. And my youngest son, Owen, my oldest son, Owen, came with us to Toronto and had an absolute ball. We lived down in the Esplanade, and there was a community group that met mother and children's community group down in the Esplanade. So we made incredibly good friends and we had an absolute ball. We've got family living in Mississauga, as everybody from Northern Ireland has. And we've other relatives living around the Metro Toronto area. So we come back and forward every so often to visit. So one of the things that I learned from Professor Urowitz and Professor Bladman was the importance of collaborative research. So you can do things on your own. So if you're in the University of Toronto or the University of Manchester, you can do work on your own if you wish. There's a single centre. But really the power of research is when you collaborate. And so since I've been in the UK, I've developed the BILAG, which is the British Isles Lupus Assessment Group, the BILAG Biologics Register, where we track people in the UK who have been treated with biologics for their lupus. And that has had a huge influence both in access to drugs and also to giving good information about the safety and effectiveness of drugs. I led the Master Plans Consortium, which was a stratified medicine consortium for lupus. But also they gave me the opportunity to join SLIC, which is the Systemic Lupus International Collaborating Clinics. And I've spent a lot of time with SLIC studying damage and then more recently developing a new damage index. So SLIC, some of you will know, includes about 45 centres across the world, a number in Canada, including Toronto, a number in the UK, including Manchester, but also the US, Mexico, Argentina, other countries in Europe, and into the Far East and Australia as well. And when you think about outcomes in lupus, you think of three things broadly. You think about disease activity, so the inflammation that fluctuates day to day, month by month, flares, quiescence, etc. And there's ways to measure that. You can measure health-related quality of life, and that's sort of asking patients how do they feel, how has their quality of life been impacted by their lupus. And the third area is damage. And damage is essentially the more irreversible things that happen after someone has been diagnosed with lupus. So that could be a cataract, that could be a heart attack, that could be a broken bone because of osteoporosis. And so the way we measure this is what's called the SLIC ACR damage index. Dr. Gladman actually pioneered the use of this. And again, the first publications were in 1995, 1996. And this is about irreversible permanent organ dysfunction occurring since the diagnosis of lupus. And there's some examples there: cataracts, kidney impairment, avascular necrosis, cancer, etc. And it's codified into a damage index that's listed on the right. And this can be scored in about 2 minutes in a clinic with a patient. But it does give you a very good handle on what's happening with regard to irreversible damage. And one of the things, this is one of a large number of studies that have shown this. One of the things we know that is if people get more damage, then the risk of mortality is increased. And that's important because if you want to do studies of improving survival in lupus, if you only looked at mortality, you would have to set up a study and wait 20 years to accumulate enough numbers to do the studying. But if you look at damage, then you can begin to get a handle in what's happening at an irreversible level that might then influence longer term outcomes. So it's really important when you're studying this in cohorts, etc. And so the SLIC cohort was set up in 2000. And essentially what happened was that patients who were recruited were then followed every year. And every year we filled in a SLIC damage index. We filled in lots of other detail about the patients as well, their disease activity, the treatment that we're on, etc. And we had blood samples stored at every sample time point. And the reason I highlighted 1700 because what this tells you is when you do studies across international boundaries with 40 different centers, you can get huge numbers and begin to really understand what's going on, not just in one country, but across the globe. So we have patients recruited from Canada, US, Mexico, Europe, and Korea, a wide range of race ethnicities. At the start of the cohort, people have relatively high disease activity and they're on a spread of medication. So a very representative group. And one of the things we found is this is a so-called spidergram. And what you see here is that if you take people on the black line on the outside are people with no damage. And the further out you are on the circle, the better your quality of life. So you can see that people with no damage have got better quality of life than people with damage. And if you look at the pink, purple rings in the middle, the more damage people have, the worse their quality of life is. And that's not a surprise, because you can imagine if somebody has got limping with a hip, or has a cataract, or has had a heart attack, or is breathless because of scarring in their lungs, the quality of life is poorer. The reason we're interested as well is because that damage begets further damage. So if you look at the red line, which is going down faster, that's the probability of staying without worsening of damage. So if someone has damage very early in their time as a lupus patient, they're much more likely to accumulate future damage over time. So what the trick then is to actually diagnose early and prevent the initial damage occurring. And what we found in this study, and there's lots of things in here, but the basic message here is that if you think about damage accrual, so people with no damage developing damage on the left, or people with damage who get further damage, there are certain factors that drive this. So men tend to accumulate more damage. The older you are at diagnosis, the more damage you occur. We found actually that if you lived in the US compared to living in Europe or Canada, whether both blacks and whites living in the US had a higher rate of damage accrual. And that might be something to do with access to healthcare. Asians, however, had a slower rate of damage accrual. And that there's some evidence that people from a Korean background are much more responsive to current therapies and therefore may do better. But I've highlighted at the bottom certain things that you would describe as potentially modifiable. You can't change your age, you can't change your racial background, but steroid exposure is associated with increased risk of damage. Antimalarials tend to be protective. High blood pressure drives damage, and the SLE is a measure of inflammation. And what this tells you is the more inflammation over time, the higher the rate of damage. So that gives you a theoretical model of damage. So we know that steroids are associated with damage. We know that disease activity is associated with damage. And then we know these fixed factors as well. So how would you go about slowing down the rate of damage? Well, essentially, for both, it's the same approach. Antimalarials to try and stabilize the disease, maybe earlier use of immunosuppression, azathioprine, mycophenolate, drugs like that. But then also targeted therapy. Some of these new biologics are much more targeted to control inflammation, and they both have steroid-sparing effects, and they also control disease activity. So you would expect that those may be able to reduce damage accrual. This was a collaboration we did with Dr. Urwitz, and we looked at organ progression in patients from a trial of belimumab. And what we did was we matched them to patients who theoretically looked the same in the Toronto Lupus cohort, who didn't have a biologic. And this is called propensity matching, and there's a statistical way you can do this. But what you can see with these curves is the orange curve with belimumab is going down at a slower rate than the usual care curve from the Toronto clinic. So an expert clinic using the best of care currently available outside of belimumab, there's more damage accrual. So that tells you that belimumab is likely to be slowing damage down. Did exactly the same with Professor Tuma, more recently with anifrolumab, which is another new drug for lupus. And again, by matching between anifrolumab long-term use and similarly matched patients from the Toronto Lupus cohort, you can see a slower rate of damage over time. So that suggests that these new drugs are going to have a benefit for patients long-term. The other nice thing about doing this work is, and by highlighting everything that we've highlighted, we've also influenced guidelines in lupus. So these are European guidelines. I'm not going to read them all, but essentially what they tell you is that one of the overarching principles is evaluate damage in patients, think about how you're going to treat patients to improve long-term outcomes. You want to think about the drugs you use and the treatments that you use so that you can help prevent organ damage occurring and get in early, prevent flares and prevent organ damage. And then the other thing that we did in the European guideline was we said, because glucocorticoids or steroids are one of the driving factors for damage, we want to get people as low a dose of steroids as possible and off them if possible. And the way you may need to do that is to modify their background immunosuppression or add a biological agent. So therefore, you're driving the steroids down to prevent them driving damage. So I'm also then just going to tell you a little bit about updating the damage index. So this index was developed in 1996, and I don't know how many of you were in the healthcare system in 1996, but you will know that medicine has changed an awful lot in 30 years. It goes without saying. We've got incredibly better ways to diagnose things, much better measurements of what's happening in your kidney, what's happening in your heart, what's happening in your brain. So we thought it was timely to think about updating this index. One of the reasons we did that was because if you look at the range within the damage index, there's a huge list of factors here on the right, as you can see. And if you could score every single one of those, the potential total score is about 45, okay? But if you look at this slide of populations with lupus, and these are multiple studies done in multiple parts of the world, you will see that even after 20 years, on average, or usually, the score at the end is between about 1 and 3, which means that we're not using the full range of the scale, which means that there's a lot of redundancy and what's called a floor effect. A lot of people score 0 in the damage index. And therefore, if you're studying this in populations, it's not a very sensitive test as to what may be going on with organ dysfunction. The other thing is when we look at the definitions that we use, modern medicine uses much more modern techniques to define things. So if you take the example of pulmonary fibrosis, so the third one down here, that's scarring in your lungs. On the old index, they used a chest X-ray to evaluate that. So you'd put a chest X-ray up. If there was scarring, yes, you had pulmonary fibrosis. If there was no scarring on the chest X-ray, you didn't have pulmonary fibrosis. But virtually nobody uses a chest X-ray now as the primary diagnostic for pulmonary fibrosis. We use breathing tests and we use high-resolution CT because you find a lot more pulmonary fibrosis if you do that, and then you can treat earlier. Also, if you think about cardiac problems like dysfunction of the left ventricle, in the current index, that's assessed clinically and with a chest X-ray. But everybody uses echocardiography now to assess the function of the heart. You get much more accurate measure of heart function. And even kidney impairment, the way we've defined that has changed over the past 30 years. The other thing that's always bothered me about the current damage index is this idea, which is that the damage is only scored if it occurs after the diagnosis of lupus. But many of you will know, and you've probably heard talks on this, you're born with a genetic risk for lupus. There are probably early life influences that put you at further risk. We know you can develop autoantibodies up to 20 years before you get lupus. And many patients have very non-specific features for a long time before they get fully diagnosed. And one question I always thought was, well, what happens to people who get major events because they're in the process of developing lupus but haven't had the diagnosis yet? And I'll give you 2 examples. I have a patient who was diagnosed with antiphospholipid syndrome, and her antiphospholipid syndrome was so bad that she had a major clot in her vessel in her leg, and the leg became gangrenous and she had an amputation. 2 years later, she developed lupus with kidney disease, rashes, and arthritis. But whenever you score her damage index, the rule would say you cannot score the fact that she lost a leg 2 years ago, despite the fact she was on the way to developing lupus. We also have people, and some of your your members may have been diagnosed with something like mixed connective tissue disease first, and they may have had scarring in their lung because they were diagnosed with mixed connective tissue disease. And then 2-3 years later, they were diagnosed with lupus. But again, then the scarring of their lungs doesn't count because it occurred before the formal diagnosis was made. So we want to try and correct that. So we've got this initiative going with the SLIC, Lupus Foundation of America, and the ACR to recast the index. And we started off with defining a new construct. And I'll not go through this, but essentially what it tells you is that this is about physiological impairment in organs. It can occur before the diagnosis of lupus if it's attributable to a process that looks like lupus. While the damages are reversible, once you've got it, it's there, people may functionally adapt afterwards. So you all know people who have recovered after a stroke so that they may get full function back again, but they still had a stroke, so you'd want to record that. And we want to use this primarily in clinical trials. So we had a huge effort to develop this. So we generated experts from across the world. We included patients, and we actually wrote to Lupus Canada, Lupus UK, LFA, and Lupus Europe to provide some patients for this study. And the first thing we did was we asked people, what clinical things do you think could drive damage in these patients? And they suggested over 220 items. And of course, you can't put 220 items into an index because nobody will ever use it. So we tried to then say, can we cluster them down? How appropriate are these things? And slowly, gradually, we began to chip away till we got down to about 190 items. We then had a further committee that looked at these and said, look, okay, some of these are really, really rare, and therefore maybe only 1 or 2 patients in a large cohort will have them. Maybe they're not that feasible to measure, and maybe they don't actually reflect the construct of damage. Maybe they more reflect inflammation. So we then removed a number of items in that way. And then our experts on organ system groups, which included maybe kidney specialists or heart specialists, etc., also looked at the items and said, no, some of these are not appropriate. But they also then gave us definitions for each of the items as well. So we ended up with 39 candidate items, and we're now looking at those as a potential structure of a new index. And these are just some examples of what we've got at the minute. They're still in the draft stage, so they've not been published, but I'll show you a few examples. So we've given everybody a definition, and we've said, this is what we mean by damage. It has to be present for more than 6 months, except for some exceptional items. If it occurs after the diagnosis, then you record the fact that it's happened. If it occurs before the diagnosis of lupus, if you think it was something like an antiphospholipid syndrome or an MCTD type thing, then you can score it. So now for something like neuropsychiatric, one of the items is stroke. And there are 3 things that you could have. You might have had a scan that said you've had something that looks like a stroke, but you may not even have known you had it, but we want to score that anyway. Some patients have had a single stroke and others have had more than 1 stroke. In eyes, what we've done is we've noted the fact that there are some people who are found to have cataracts who don't have any blurred vision. They just go to their optometrist and they say, oh, you've got a small cataract there. So we want to record that even if it's not causing any visual loss. Equally, some of you may be told to stop your antimalarial because there's some changes at the back of the eye. There's no visual change associated with it, but we want to record that. But then there's people who've got partial visual loss, or maybe complete loss of vision in an eye, or bilateral loss of vision in an eye. So those are more severe forms of eye involvement. And somebody with kidneys, we've taken the international definition of kidney impairment now, which is defined by a group called KDIGO, and then we've grouped those into levels of severity. And we've also taken into account what's on the kidney biopsy, because the kidney biopsy often helps you work out if people have got scarring in their kidney already. And now we're at the stage of trying to weight these, because you can imagine if I said to you, you've got a cataract that's not causing any visual impairment, and you compare that with someone who's had a heart attack, you would probably say, well, actually, the heart attack is probably more severe than having a small cataract. So we're trying to weight those and try and work out how we can weigh those for the future. And we had a really interesting and impressive meeting in Manchester in October, which included physicians from Africa, as well as physicians from the Far East, North America, and South America. So a really representative group of populations. So then just finally, I've now gone a full circle and I'm now back in Belfast, leading the Faculty of Medicine, Health and Life Sciences. And that's a very exciting place. For those of you who might have relatives, you may know where Northern Ireland is. It's a devolved health and social care system. It's about 2 million of a population. Its healthcare system is under a lot of pressure. We've lost a lot of GPs recently. About 500,000 people in Northern Ireland live with a musculoskeletal condition. There's big gaps in healthy life expectancy, maybe about 11 years between the most and least deprived men, and about 15 years between the most and least deprived women. There's a very high mental health burden because of the previous troubles in post-conflict society that we have, and very high rates of economic inactivity, people in working age who can't work because of poor health or other reasons. And if you take a map of Northern Ireland with deprivation, the darker purple areas around Belfast and around the border areas have got high deprivation. And you can see that cardiovascular disease is most prominent in areas with high deprivation, and cancer incidence is higher in our more deprived communities. So the idea and the strategy in Belfast now is to try and match what we do at the university with the population and civic need of our region, which then will have global impact. So in summary, there are new targeted therapies that reduce and modify disease and damage progression in lupus, because we know that better disease control spares steroids and reduces or eliminates flares. Novel approaches have the capacity to reduce and reverse damage. There are new treatments that are coming out, which I think are going to have a major impact on prognosis, antifibrotic therapies, regenerative therapies, etc. And then the stick damage index as it stands has got some limitations, and we want to try and fix those. So we've now developed a new damage index. We've got a construct, we've got our items together, and we're now trying to look at validate what we do next. So there's a huge number of people who have worked on this, including the project team in Manchester. Dr. Johnson, who works in Toronto, has been helping us as well. Professor Gladman has been centrally involved from Toronto. A big thank you to the ACR, SLIC, and Lupus Foundation of America who have funded us. But I think the final thank you should be to the Lupus Ontario yourselves, because I guess I'm the class of 1996, and it was a huge privilege for me to work in Canada. It gave me a huge break in my career, and I think over the last 30 years, I've continued to contribute to knowledge in lupus, but it was the Geoff Carr Fellowship that got me going. So I think your investment reaps rewards globally, and I think you should take great pride in the schemes that you provide. So thank you all very much, and that's the university in which I work. So thank you all. Come visit Belfast someday. Thank you.
Thank you so much, Dr. Bruce. I just want to remind people, if you have any questions, you can put them in the Q&A function. I will be reading the questions out loud, so there'll be no other verbal questions other than coming from me. So please enter any questions or comments. But Dr. Bruce, thank you so much. Because you were one of our first few fellows, like you said, you got right in on the ground there. And I absolutely love that you are still continuing such incredible work, and that the work you're doing has a global impact. And I was thinking when you were talking to me, these details are very fascinating, but the research you're doing is perhaps not as sexy as something directly related to how do we reduce literal kidney damage kind of thing. But what you're doing actually has almost a wider impact, because every patient gets assessed, and because we know as Luppies, we're complicated and we might not remember all the things we need to talk about. Having an index that the doctors check is helpful for rating, but you're right, it absolutely needs to match the diagnostic tools and the times we have. For Luppies who are listening, so your doctor does assess you on this at most or all of your visits. They just might not pull out a chart and say it, but they're asking you about all the details, and that's where they're recording this. So all of us get assessed on it all the time. Is there anything that you feel that we as patients should be doing to help give some more definition to the doctor in these areas? Like, for example, should I be thinking about all of my organs, including my eyes, when I talk to my doctor and mention something, whether it's good or bad, or how do we kind of as patients further this along?
I think, yeah, so I think that being aware that these indices are very, very useful because it's a check system for both doctors and patients to think and be aware of the things that can happen. So therefore, if you feel you've got a little bit of blurring in your vision, get your optometrist to have a look, get an optician to have a look at you, but then also record the fact. Make sure your doctor is aware. Because something like a cataract, you might not even mention to your rheumatologist that you have a cataract, but it's important for them to understand that because that's probably telling them that the accumulation of steroid, etc., is having an impact. I think that so I think it helps improve the standard of care. And it's actually very interesting because some of our African colleagues who've been involved in this tell us that having an index like this will help them in their countries begin to raise the standard of care for their lupus patients. Because if you can't do pulmonary function testing and spirometry and CT scanning of the lung, and you're left with a stethoscope and a chest X-ray, they can lobby government and say this is not providing good standard care. So it has a global impact. Yeah.
That's really incredible. I love that your research has such a wide range across the globe, across like the cohort you had for the research, age, race, geographic location, amount of diagnosis. That's really helpful across the board. What I have heard from many lupus patients is when they do get diagnosed with this, oftentimes they haven't heard of lupus or know very little about it. They suddenly look at the details on it and go,
Mm-hmm.
oh, wait, oh, I've had that before, or I've
Mm-hmm.
had this before. But again, that pre-diagnosis state assessment is really interesting. And so
Yeah.
we might equate those to contributing to our lupus if our doctor is not paying attention or has been sort
Yeah.
of trained to make that a
Mm-hmm.
separate section. That's a
Mm-hmm.
real disservice to both us and them because then their treatment will not be as successful.
That's right. That's right. And I think, I mean, somebody told me the other day, a colleague of mine told me that they had a patient who 2 years ago had a very small clot in their eye, like a central retinal artery occlusion, and it was treated, it was managed. And then 2 years later, they come up with lupus. And then what happens is the lupus doctor checks the blood tests and they find they've got sticky blood, they've got antiphospholipid syndrome, and now they have to go on lifelong warfarin. But actually, that wasn't thought of at the time of the original diagnosis. It was just said you've a little clot in your eye. There's probably a little bit of a few platelets that knocked off or something from somewhere. So it does actually, it makes people think about people's past history in a completely different way.
It's
Great.
yeah, very fascinating. We have somebody that has said, you mentioned it indirectly, but is there research based on trauma and stress that leads to lupus or adds to damage? For example,
Yeah.
ACE score, intergenerational trauma, epigenetics, and or historical trauma that has impacted the community that increases risk. You mentioned in Northern Ireland and their history, and there is the African American population with higher
Yes.
rates and the history of slavery and racism in America. Is there specific research that considers those stressful connections?
There is indeed actually. So it may not just be, it may actually be, these may work through biological phenomenon. And it's interesting that in Northern Ireland, people who have been traumatized by the Troubles or being exposed to paramilitary violence and things like that, it's not just sort of mental health issues like stress and anxiety, but there's some physical diseases that actually are more common in those populations, um, forms of arthritis and chronic pain and things. But there's also research within the US where in Georgia and other areas where the African American population who suffer a lot of racist discrimination and because of zoning and segregation and all of these things, that actually that stress or discrimination stress, you can measure biological effects in the cells. And so I think you're absolutely right. So it may well be that it has a driving effect on this, but it's how it's how your environment, it's basically how your wider environment affects your biology, and there's no doubt that it does.
That is fascinating. So I would imagine that sharing some of the stressors in our lives may be helpful when we're talking to not just our rheumatologists but care practitioners as well, in dealing with how we kind of move forward and how we look back at things.
I think that's right. Yeah.
Do we have any other questions or comments? We have somebody who just says it's been very informative. So I think we can wrap up there, but Dr. Bruce, I just want to say thank you, not only for your care for lupus patients, for the work you're currently doing for your patients in your clinic, for the teaching, but for really doing this groundbreaking work and changing the index that will be really helpful for everyone. We really appreciate it. This is a